Good day, sir, and to those who are watching this presentation. I am Jarek Nadal from Section D, and together with Mr. Felix Cobrana from Section P, we'll discuss the pathophysiology, the nursing and medical management, as well as the prognosis and the definition of the assigned disease to us, which is cystic fibrosis. So, what is cystic fibrosis? Cystic fibrosis is a genetic disorder inherited in an autosomal recessive manner that impairs the normal clearance of mucus from the lungs, which facilitates the colonization and infection of the lungs by bacteria, notably the Staphylococcus aureus, Pseudomonas aeruginosa, and Pseudomonas cypatia. So, cystic fibrosis is a genetic disease that causes sticky, thick mucus to build up in your organs, blocking and damaging them. Many people think of CF as a lung disease because it affects your lungs and airways, which can make it hard to breathe and cause frequent infections. But it is called cystic fibrosis because it also causes cysts and scarring, which is known also as fibrosis in your pancreas. This damage plus the thick mucus can block ducts that release digestive enzymes, making it hard to get nutrients from your digestive tract. And not only that, because CF can also affect your liver, sinuses, intestines, and sex organs. The mucus that lines your organs and body cavities, such as your lungs and nose, is thin and watery. In many people with CF, a change in the gene, which is a genetic mutation, leads to a low levels of certain proteins or proteins that don't work properly. Because of these faulty proteins, minerals that move water into your mucus, which thins it out, get trapped inside the cells, leaving the mucus thick and sticky. People with cystic fibrosis are born with it. It's a lifelong illness that gets more severe over time. Most people with CF don't live as long as people without it. So there are two types of cystic fibrosis. One is classic cystic fibrosis, which often affects multiple organs. It is usually diagnosed in the first few years of your life, while the other hand is called atypical cystic fibrosis, which is a milder form of the disease. It may only affect one organ or symptom may come and go. It is usually diagnosed in older children or adults. So, moving on to the medical management, first is the antibiotics. Antibiotic is to treat lung infection guided by sputum culture results. Then the other one is inhaled beta-adrenergic agonist, which is to control airway constriction. Then Dornase alpha pulmozyme, which is a genetically engineered pulmonary enzyme to help liquefy mucus. Then we have the recombinant alpha antitrypsin to um, counteract excessive proteolytic activity produced during airway inflammation. And then salt supplements to replace electrolytes that are lost through sweat. And then sodium channel blocker to decrease sodium reabsorption from secretions and to improve viscosity. Then bronchodilators to relieve symptoms of shortness of breath, to open the airways and to allow clearance of mucus. And then lastly, the CFTR modulators to improve the production, the intracellular processing, and the function of the defective CFTR protein.
So for our um, nursing management, so we have number one, help patients manage pulmonary symptoms and prevent complication. So what we could do here are removal of pulmonary secretions, chest physiotherapy or CPT, and breathing exercises. So our intervention's objective here is to improve airway clearance. Uh, we're going to monitor the patient for signs of respiratory distress, teach the patient to cough effectively, examine and document the mucus produced, uh, encourage the patient to increase their fluid intake, and yung breathing exercise, so from the word itself, meaning we're going to improve the breathing. We're going to improve the breathing of our patient. So interventions are to maintain the patient in a semi-Fowler's position, use pulse oximetry to determine the oxygen saturation, administer oxygen as ordered, administer mouth care every 2 to 4 hours, perform CPT or chest physiotherapy every 2 to 4 hours as ordered, and teach them to exercise to help loosen the thick mucus buildup. Second is to reduce the risk factor associated with respiratory infections. So patients should avoid exposure to crowded places or area or to people with infectious diseases. By avoiding naman, syempre, uh, we avoid those people with uh, communicable disease or those disease that are infectious. We prevent ourselves from getting infected. So interventions to prevent infection, one of the most common and the most easiest way is proper hand washing or good hand washing techniques. And also we're going to teach patient uh, other good hygiene habits. And lastly, we're going to encourage adequate fluid and dietary intake. So this is to promote removal of secretions and to ensure an adequate nutritional status. Because cystic fibrosis or CF is a lifelong disorder. So patients often have learned now to modify their daily activities to accommodate their symptoms and treatment modalities. The pathophysiology of cystic fibrosis. So our predisposing factor is genetic. So this is mainly a disease that is a hereditary disorder. So maybe a family history or parents may be a carrier of CF or cystic fibrosis. This is a autosomal recessive disease or disorder. And for the precipitating factors, so precipitating factors or factors that can trigger or complicate the condition are as follows. One is infection, second is dehydration, and last is the environmental factors. So cystic fibrosis is an autosomal recessive disease. So the parents could be carrier and the child now has the manifestation of the cystic fibrosis. So, cystic fibrosis, uh, there is a mutation of chromosome 7. So, chromosome 7 is responsible for encoding a membrane associated protein called the cystic fibrosis transmembrane conductance regulator, or in short CFTR. So CFTR, uh, this gene is responsible in forming the CFTR protein. So the CFTR protein, uh, it helps regulate chloride and sodium transport across epithelial cells. So since CFTR is abnormal or does not work properly, this causes our exocrine gland to uh, have dysfunction. So we now have a problem with our secretion. So exocrine gland dysfunction goes down to impaired chloride ion transport. So let us first know the CFTR protein normal function. So the CFTR protein has a function as the chloride ion channel. So meaning uh, meaning CFTR protein is a passageway of chloride ions across membranes, and so uh, this ion channel or this CFTR protein also regulates the water and salt balance. And so if there is a mutation of CFTR protein, So if there's a mutation, uh, what happens here is that your chloride ions cannot pass through that passageway. There is a problem on the ion channel. Parang mayroong blockage or parang nalock yung passageway. Kaya yung abnormality is that nagkakaroon ng build up, nagkakameron ng build up ng mucus, and so nagkakaroon ng thickened secretions. So on our diagram presented, moving now to the left naman kita, we have the decreased reabsorption of chloride ions to sweat gland cells. So here, since CFTR protein is abnormal, it cannot absorb the chloride ions. There, what's happening here is there's a trapping situation. So natatrap yung chloride ions, and those trapped chloride ions are now secreted to our sweat glands. Kaya yung ating sweat, uh, yung sweat ng mayroong CF is salty. So therefore, decreased reabsorption of chloride ions, uh, this results to increase to chloride ions in your sweat. Kaya yung sweat is salty. So the diagnostic test for this is the sweat chloride test. So this is a simple diagnostic test that measures the concentration of chloride ions in the sweat, or it measures the chloride concentration. So after performing this test, sweat chloride concentration of 60 millimole per liter or greater confirms that the person has CF, or cystic fibrosis.
Going back to where the secretion thickened caused by the altered chloride channel, it leads to dehydration, which increases the viscosity of the mucus gland secretions, resulting in decreased clearance of mucociliary secretions. Thus, there will be an accumulation of secretory passages throughout the body, obstructing the lower and upper respiratory tract, the pancreatic duct, the bile duct, and the intestines. CF affect a number of organs, but this pathophysiology will especially focus only on lungs. So, in chronic respiratory failure due to the accumulation of retained secretion in the um, lower respiratory tract, particularly in the airways, bacterial proliferation may happen, resulting in airway infection and inflammation, causing reduced airflow. Thus, there are persistent respiratory infections which can progress to chronic bronchitis with or without bronchiectasis. Now, there is inflammation and irritation of the bronchial tubes which causes mucus to build up. With bronchiectasis, the bronchial tubes are permanently damaged, widened, and thickened, resulting in higher probability of frequent infections and blockages of airways. This allows the bacteria and mucus to build up and pool in the lungs. Now, the patient with chronic bronchitis will then show signs and symptoms like cough, production of mucus, fatigue, fever, and chills. And this can be treated using the chest physiotherapy, bronchodilators, and CFTR modulators. To diagnose naman the chronic bronchitis, you can use the pulmonary function test, the CT scan, and the sputum test.
Now, for our prognosis, a good prognosis for a patient with cystic fibrosis involves maintaining a stable lung function, effective management of symptoms, and potentially living into their 40s or 50s or even longer. So this is thanks to modern treatment like CFTR modulators. So on the other hand, a poor prognosis may result from frequent lung infections, severe respiratory decline, and complications like CF-related diabetes or liver disease. This leads to a shorter lifespan and reduced quality of life. The prognosis is highly variable, so depending on the treatment response and management of the complications.